I would like to present our next speaker, last but not least, inshallah, Dr. Nadine Galal, Assistant Lecturer of Pathology at Faculty of Medicine, Alexandria University. Dr. Nadine presentation entitled, "You Can Bury the Past, but it will haunt you." Dr. Nadine, can you hear me?
Yes, can hear you, Dr. Muhammad.
Yes, go on.
Okay. Good afternoon. I'm Nadine Galal, Assistant Lecturer of Pathology at Alexandria Faculty of Medicine, and today I will present a case entitled, "You Can Bury the Past, but it will haunt you." First, I would like to thank Professor Dr. Basma Sab for such a great opportunity. Our case today is a 28-year-old female who presented to the urology clinic complaining of repeated attacks of hematuria. Imaging and cystoscopy revealed the presence of a bladder mass. A 2-RBT specimen was received as multiple tissue fragments measuring collectively 3 by 2.5 by 1. Microscopic examination revealed the presence of an infiltrative neoplastic growth that dissects its way through the muscularis propria of the bladder. The tumor consists of diffusely infiltrating cells, some of which are polygonal with abundant eosinophilic cytoplasm and large pleomorphic nuclei, while others exhibited clear vacuolated cytoplasm and an eccentrically placed nucleus, giving a signet ring appearance. The striking finding was the presence of a fundic-type gastric mucosa among the submitted fragments, which was also infiltrated by the tumor cell nests. So what's the differential diagnosis of signet ring cells in a bladder biopsy? It includes primary signet ring cell adenocarcinoma of the urinary bladder, which is extremely rare, a direct extension from a rectal adenocarcinoma, and finally metastasis from a breast infiltrating lobular carcinoma. Immunohistochemistry was done. Cytokeratin 20 was negative, which excluded any possible colonic origin. Cytokeratin 7 showed diffuse positive staining in tumor cells, while GATA3 negativity excluded both breast and urothelial origins. So what's next? On contacting the surgeon, he reported that at the age of 5 years, the patient underwent a bladder augmentation surgery for the treatment of contracted bladder, where the most commonly used grafts are usually of enteric origin. However, this didn't explain the negativity for cytokeratin 20 or the presence of the gastric-type mucosa. Is it metaplasia? However, the gastric mucosa was so orderly arranged, it didn't even resemble the pyloric gland metaplasia described in association with chronic inflammatory conditions like IBD or chronic cholecystitis. So the first thing which popped into our heads, can we use a gastric graft in cystoplasty operations? On recontacting the surgeon, he reported, yes, but it's very rare and was used only in the past. So this case was signed out as a case of a poorly cohesive gastric carcinoma, signet ring type. By the way, this is the new nomenclature per the latest version of the WHO classification, 2019. Augmentation cystoplasty is a surgical procedure used for the treatment of neurogenic bladder complications such as overactivity and low compliance. This procedure involves the anastomosis of the bladder with gastrointestinal grafts, usually from portions of the ileum, colon, or stomach. An uncommon but a very important complication of bladder augmentation is the development of malignancy, which was first reported in 1971 by Smith et al. The first case of signet ring carcinoma arising following a gastrocystoplasty operation was reported by Bider et al. In 2005. The median latency period between surgery and a malignant tumor has been reported to be 19 years, quite similar to our patient. The most common histologic tumor type is usually adenocarcinoma. Multiple different histologic subtypes were described, including adenocarcinoma, mucinous carcinoma, ignitrine carcinoma, and other types include urothelial carcinoma, squamous cell carcinoma, neuroendocrine carcinomas, and rarely a few cases of leiomyosarcoma. The pathogenesis of adenocarcinoma following augmentation cystoplasty is poorly understood. Several possible mechanisms have been proposed. The production of the carcinogenic nitrosamines by bacteria has contributed to the development of malignancy. Increase in the molecular alterations occurring near the enterovesical anastomosis. The direct toxic effect of urine on the enteric epithelium. And finally, the removal of the enteric epithelium from the intraluminal nutritional supplies. An interesting observation from one case series is that only one of the patients subsequently developed carcinoma at the native site of the gastrointestinal graft. Chronic irritation of the gastric mucosa by urine over the years might induce atrophy and intestinal metaplasia, which could be followed by in situ and invasive carcinoma. However, this is not the case in our patient. As we know, there are no known risk factors for the poorly cohesive type of gastric carcinoma. So our very unlucky patient should be consulted that she's at a risk of developing malignancy at the native site of the gastrointestinal graft. Take-home messages. In the era of molecular, even immunohistochemistry can be deceiving. So histology is always the key to diagnosis. And of course, multidisciplinary approach is mandatory to solve problematic cases. Thank you so much for listening and have a nice day.
Thank you so much, Dr. Nadine. Such an interesting case, and will never be solved without good communication with the surgeon and good clinical history and good overall documentation of what the patient have performed or have been exposed to either in the past or in the present. Thank you so much all for your